Welcome back to episode 9 of the Rehab Exercise and Sports Therapy podcast, sponsored by Universal Orthopedics. A special shout out to our editors, Mark Hom and Nancy Kraus, who do an amazing job with making this podcast look infinitely more professional than I ever could. I am happy to be joined today by Dr. Kate Jochimsen from MGH and Harvard. I reached out to Kate because I had heard her speak at Is it YAHIR? I don't know. I never know the right way to say that acronym, right? It's the Young Adult Hip Research Collaborative, right? I had heard you speak there a couple times. And one of the specific reasons I wanted to reach out to you was obviously there's a ton of research out there on psychosocial influence on low back pain, ACL stuff now. But you, I think, were one of the first people I ever heard speak about it in relation to hip. And even more importantly, you have offered in some of your articles some actually interventional stuff too, which is one of the things I am definitely hoping to pick your brain about today. So I'm looking forward to that. But Kate, if you could, I'll let you give a little bit about your bio and your role, and a little bit about what you're doing research-wise.
Yeah, absolutely. Well, thank you, Dan. It's so good to be here. It's good to meet you. I'm glad we're connecting. I'm Kate. I am clinically trained as an athletic trainer. I have my PhD in rehabilitation sciences from the University of Kentucky, and then I did a postdoc in biomechanics at Ohio State University. As a clinician, I have over 12 years of experience working with high school and collegiate athletes mostly. Currently, I'm a researcher at Massachusetts General Hospital at the Center for Health Outcomes and Interdisciplinary Research. And I'm also an assistant professor in the Department of Psychiatry at Harvard Medical School. And my research, I like to say it really bridges the gap between sports medicine and psychology, but there's sort of like three main pillars within that. One is just understanding chronic pain broadly. Most of my work, of course, has been in musculoskeletal or hip pain specifically, but recently been also branching out into chronic pelvic pain. The second sort of pillar would be psychologically informed practice, which I'm sure is a lot of what we're going to talk about today. So developing, rehab delivered psychological and mind-body interventions, training clinicians on how and when to intervene with psychological response to injury or pain. And then sort of the third thing I focus on is hip joint injuries. And so understanding how do those injuries progress over time? What does treatment response look like? And how can we develop new treatment targets and interventions to enhance our clinical outcomes? And I think, for anyone listening, that line from point A to point B was very not linear. I didn't set out to join a psychology lab. I'm super happy to be there now, but the journey I set out on was really to understand why some patients weren't getting better after hip arthroscopy, right? Like if morphology was the problem and the pain generator, and then we went in there and surgically corrected the pathoanatomy, why were so many patients still struggling with persistent pain? And so I guess what I've learned over the last decade of doing this work is that it really has to be 100% patient specific. It's a combination of mindsets, movement, strength, and I'm sure other factors that we don't even understand yet really. But mindsets play an undoubtedly important role in the maintenance of chronic hip pain.
All right, awesome. So, okay, if it's okay with you, I wanted to kind of approach today a little bit from like a clinician standpoint, because I think that's what most of our audience is. I definitely want to get in, again, I'm not married to like a specific agenda, so I kind of want to let the conversation drift wherever it needs to go organically. But one of the things I know, as a clinical person, from a hip standpoint, there's a few different hip scales. And I know typically, like I've defaulted whenever it comes to some of the psychosocial concepts to Tampa Scale of Kinesiophobia. But in terms of just identifying and kind of screening standpoint, is there one specific hip scale that's kind of your go-to? Is there one that kind of has the best psychometric properties? I was wondering if you could kind of give us a little bit of insight about that. If you had to basically pick one, which would you go with?
Yeah, which child would you pick?
Exactly.
Yeah, it's a tough question. So, I think that really what we're trying to identify is who needs help, right, with their psychological response to their hip pain?
Right.
What do they need help with? So that's sort of the question of which scale do we choose? And then that leads us to how can we help, right? Because we have to select an intervention that's going to then target that mechanism or whatever it is they're struggling with. And so I think that in the hip literature, we've seen a wide variety of scales used to measure both functional pain, functional and psychological constructs.
Right.
If I had to pick one and I was a clinician, I would honestly pick the OSPRO because it is going to give you a lot of different metrics with one scale. So I work a lot with Dr. Trevor Lenz. He's at Duke University, and he was one of the developers of that scale. And it's going to give you a lot of information with fewer questions.
Okay.
So from a research perspective, we like to use a few different scales because we really want to measure these mechanisms. So we want to measure pain catastrophizing using the pain catastrophizing scale. We want to measure confidence or self-efficacy using usually the pain self-efficacy questionnaire. And then I often do also use the Tampa Scale for Kinesiophobia. So those are the three screeners that I use. And I use all three because they really are measuring distinctly different things. And so my interventions are going to be different based on which of those scales patients flag high in.
Sure.
Yeah, so that would be my short answer. As a clinician, I would pick the OSPRO. As a researcher, I want more granularity.
Sure. Yeah, absolutely. Okay, fair enough. I like how we parse that out a little bit. That's good, because what we find sometimes is, again, like, we barrage patients with this intake paperwork and that kind of thing. So I'm always looking for, like, okay, which is the one I can give them that they will tolerate filling out one more sheet of paperwork.
Yeah. The other thing I think is important to add here, two things. One is, I think it's important to have the conversation about why we're giving these measures to patients, right? We're not just trying to sneak a psychological questionnaire in there without context and hoping they don't ask or, won't mention it. I think it really can go a long way in terms of trust building and really helping patients understand all the levers that can be impacting their pain experience when we're open and honest about that conversation. So I'll just give that plug up front. And then the other is for people who are having a hard time integrating these patient report outcomes into their clinical practice, just talking to our patients can also give us a lot of good clinical information, right? So asking things like, how are you coping?
Yeah.
What do you do when you experience symptoms, right? What are your health behaviors when you start to feel hip pain? What kind of thoughts go through your mind when your hip starts to hurt, right? And then listening for things like, I feel terrified. I immediately stop whatever activity I'm doing, right? And really listening for, okay, what is the patient telling me their emotional or cognitive process is when they're experiencing pain? And I can get some of that information without a patient report outcome measure.
Yeah. So one thing I want to ask you about, Kate, also is in terms of using the scales and maybe kind of customizing it to the individual, right? I feel like hip pain becomes this nebulous, catch-all umbrella, right? I mean, I know Doha Agreement tried to really parse it out a little bit, right? And I guess there's some mixed consensus on how well it actually did that, right? But I feel like we're lumping it all in, but I know greater trochanteric pain syndrome and the demographic with that is very different than what you'll see from a more athletic FAI patient population, that kind of thing. So do you find, when you're looking at that, is there a specific category as far as some of those things you mentioned, some of the themes as far as pain and self-efficacy, pain catastrophizing kinesiophobia, do they tend to kind of vary depending on that demographic and that diagnosis? Or do you find anybody with this chronic hip pain tends to kind of demonstrate a similar type of pattern or presentation?
Yeah, that's a really good question. And I, love how sort of honestly we're talking about this because it's messy. Hip pain
And there's a lot of
specifically.
overlap between different pathologies, right?
There's a lot of overlap. We very rarely have patients who have just one diagnosis, right? So we can talk about this in these categories, but often there's multiple things co-occurring. And to make it a little bit more complicated with my answer, I'm actually going to say that I would even go further than that and say that I have not found in the literature or in my clinical experience or really have a good theoretical foundation for why I would think this would differ based on any pathology. Because it's a human response to pain, right? And so I think that, we're seeing this, right? It started in chronic low back pain. We moved it into ACL reconstruction and return to play. Now we're talking about it in chronic hip pain. We're talking about it in chronic shoulder pain. it's sort of infiltrating. I've seen some stuff in chronic ankle instability. And the take home really is that it's not going to affect every patient. Some patients are going to come in, they're super resilient, they're super confident, they have good coping skills, they have good social support, and maybe this doesn't need to be part of their treatment plan. But we still need to have that conversation, understand, is this something that's impacting their recovery? And that's just going to be true for every patient that walks through the clinic doors.
Sure. Okay. Makes perfect sense. Tell me then, just again, to avoid kind of reinforcing some of those things sometimes, how often do you rescreen them with those scales? Like at what frequency or that kind of thing
Yeah.
what's really like the minimal time window you need to see some sort of changes or to really be able to monitor that effectively?
Yeah, no, good question. So I would say my sort of framework for psychological screening is, always at initial eval. So whether
Okay.
that's baseline, pre-op, whatever it is, get those metrics. And then, you want to do it sporadically over the course of their recovery, because especially if you're doing any types of interventions, you want to know, are these interventions working? Are we seeing improvements, or do we need to change course? Right. And the other important thing is someone at baseline might screen fine, right? Like they're not struggling, but needs can change throughout the course of recovery. So someone
Sure.
who's not struggling early on might start struggling later, and we would miss that if we didn't rescreen. So I think it's going to sort of depend on the length of time you're with them, how many sessions do you have? Like there's so many things that sort of go into this calculus. Um, I think that rescreening every few weeks is probably a good rule, and definitely at those important time points, right? So baseline, when you start return to function, and certainly before return to play. Like you definitely want to
Yeah.
make sure you're hitting those high points.
Okay. All right. Fair enough. So if you could, I mean, I might have glossed over a little bit for our audience here. Do you mind some of these factors we're talking about, like the pain and self-efficacy, the catastrophizing and the kinesiophobia? Do you mind like defining that a little bit more in kind of the Cliff Notes version, I guess, for our audience in terms of like what that would look like and what that would be, yeah,
Yeah.
or what those behaviors would look like clinically?
Yeah, absolutely. So I think it's important that we start talking about these because, these terms kind of get thrown around and it's like, what are we
Yeah,
really talking
exactly.
about here? Yeah.
Yeah.
So pain catastrophizing is really a concept that's going to be measuring pain misconceptions or cognitions about pain that are true or untrue, right? Beliefs about pain.
Yeah.
Um, Pain self-efficacy is going to be a patient's confidence in their ability to do their daily tasks despite the fact that they have pain. So it's sort of a confidence related construct.
Sure.
And then kinesiophobia is going to be fear of painful movement or re-injury. Now, that's like the Cliff Notes version.
Yeah.
But I think it's
Right.
really important that we also look at the individual questions on these questionnaires. Because, for example, the Tampa Scale for Kinesiophobia measures fear of movement or re-injury. And we think fear, right? Like that's an emotion, and it is, and it has some
Right.
questions regarding emotions, but it also has questions that are measuring true or false statements about pain cognitions. So
Yeah.
is it true or false that tissue damage equals pain, right? Like that is a question on the
Yeah.
TSK. So if they score high on the TSK and I didn't look at the individual questions, I'm just going to be like, okay, what can I target high levels of fear with? What's in my toolbox? Right. And that's fine. But they might also need an intervention to correct pain misconceptions. So we can use the scales, we understand the constructs, but we also need to look at those individual questions to get that granularity.
Okay. All right. Perfect. So one of the things I read in kind of reviewing some of your published papers was that I like really hit home for me was the mention of imaging, right? And its relationship to some of the catastrophizing and kind of the translation from somebody obtains their imaging findings, the radiology report, right? That says, you've got extensive labral damage or that kind of thing, and that translates into catastrophizing for them. But the flip side of that, right, is we know, especially with FAI patients, there's a huge percentage of patients that have all these incidental findings that may be quote unquote defined as pathologic that they're walking around asymptomatic, right? So how do you see that translate? And when you see that, I guess when you've identified that in a patient where they come to you and hand you this with like this look like their dog just died. You know, they hand you their radiology report. Like, how do you address that with them?
Yeah, this is a really important question. And I think
Yeah,
this
right.
is, yeah, this is really getting into the meat of some of the simple clinical changes we can make that I
Sure.
think, this is my personal opinion, are going to have profound impacts on the way our patients respond in rehabilitation.
Yeah.
You know, it's really, really hard to dig yourself out of the hole of a patient walking in and saying, I have a cam lesion and a labral tear, and
Right.
therefore, why am I even here? Right? Like, I need
Sure.
surgery, right? Like, that's a hard
Yes.
hole to dig yourself out of. And so, being really careful, and this starts with our physician colleagues, the people who are having these conversations, right?
Yeah.
The language that we use is so impactful. And so
Absolutely.
I think that really walking people through what you were talking about before, right? That first of all, we're using the terms that are recommended in the Warwick Agreement, right? We're talking about this as CAM morphology, pincer morphology. These are
Yes.
variants of morphology that may or may not be impacting the pain that you're experiencing right now. We know that about half of athletes have CAM morphology. That doesn't mean they
Right.
all have pain, right? And
Exactly.
so there is this disconnect between what we see on imaging and what patients experience. I think it's also really important to provide the same context for labral tears, right? Like, yeah,
Sure.
this scan found a tear in your labrum, and that may or may not be impacting the pain that you're experiencing right now, right?
Right.
70% of the people in this room probably have a tear in their labrum
And you know,
and
yeah,
may
exactly.
not
Yeah.
have any hip pain. So I think that the message is really being cautious with the language that we're using, being consistent across providers and how we're describing what we're seeing, and really providing hope, right? Because the message to
Yeah.
me is one of hope, right? Like, this is great news because that means we can find all these other impairments that may be turning the dial up on your pain and work together to address those, and therefore maybe turn the dial down on your pain, right? Like, we
Right.
don't necessarily need to change this morphology. You can be asymptomatic with this morphology. And that is great news for rehab providers.
Absolutely. Yeah. And I mean, I think sometimes if you like, it can't change the anatomy, right? But you've got super weak glutes and
Mhm.
super tight hip flexor and all these things that we can impact, right? To at
Right,
least kind of trial before we jump, like you said, right to surgery, right?
right. Yeah.
So on that note, I wanted to shift gears a little bit, if I could, Kate, to some of what we see as far as motor manifestations with this,
Mhm.
right? Because we know there have been a ton of biomechanical studies in people with hip pain, right, where we see kinetic chain changes with squat pattern, with walking, with jumps and drop jump landings and that kind of thing. So I wanted to kind of pick your brain because I think you had a really interesting paper on this concept of dynamic hip stiffness, right, and how that plays
Mhm.
out. So if you could maybe just elucidate a little bit or kind of give us some background as far as what we tend to see in some of these chronic hip pain patients. And then we can maybe touch a little bit on screening too, if you don't mind.
Yeah, no, absolutely. I'm only giggling because it's like every can of worms is just like another we don't know box.
This
Um,
nebulous, yeah,
right.
exactly. Like, yeah, right, yeah, I hear
So,
you. Yeah,
I mean, there are a lot of great people doing work in the space of hip mechanics.
sure.
And there's a lot that we don't yet know. I think that one of the challenges is that we don't have a strong consensus on what specific motor control or movement patterns are associated with hip pain in this patient population. And that goes
Okay.
for patients with femoroacetabular impingement syndrome or dysplasia. We did have in 2018, Matt King had a great systematic review that said like maybe there's some reduced motion in the sagittal plane, but at this point it's inconclusive. A lot of the studies, one group will find something, we can't repeat it with it, another group can't repeat it. So it's tricky. We know they move differently. Like, femoral acetabular impingement syndrome is a movement related disorder. We know that there are movement impairments in these patients. The problem is nailing down what are those movement impairments, and is there a consistent theme amongst patients presenting with a similar clinical presentation? And that's sort of where we're stuck. So I think the take home from a clinician perspective is that this patient walking in the door with hip pain probably is moving differently than someone without hip pain. How they're moving is going to be very specific to that individual. So you sort of got into this idea of screening. And I think that's how we answer that question, right? Is by screening all of our patients. And so I think that it's really important in patients with hip pain that we are encouraging them and testing their movement in single leg dynamic tasks, because oftentimes in these
beat me to that question.
Yeah, okay.
Right. Yeah, perfect. You set me up perfect. So
Yes. Yeah.
All
So, I think that oftentimes in these double leg tasks, we're able to mask compensations, right? Because we're doing something on two legs instead of one. And so single leg tasks are really necessary in order to adequately load the hip to avoid those bilateral compensations. Now, in terms of like, what should that task be?
Yeah. You anticipated that one, huh?
Yeah.
Yeah, I mean, because that's always the question, right? Is it
Right.
single leg quad? Is it step down? Is it like Y balance? And
Right.
in terms of literature, like which is the best? And I'll let you answer if there's a kind of universal consensus or not. But
to my knowledge, there is not a universal consensus. I know that different groups are using different tasks. I think that as a clinician, I usually do a single leg squat, but I also am usually going to ask the patient, what is pain provoking for you? Right? Like, when do you notice your symptoms? What do you do in your daily life? And then I'm going to have them try to replicate that task. It might be a more sports specific task. It might be going downstairs. It might, like, whatever it is for that patient. I'm going to be looking at how they're moving with regards to the task that's symptom provoking for them. So yeah, I don't think we have a clear consensus on what is the best task. I think we have consensus on it should be a single leg dynamic task. But that's as much consensus as, and I could be wrong. I'll be curious what other hip folks have to say, but that's my read of the literature.
From my, again, from what I've read, I completely agree, but obviously I am not, as nearly as well versed in literature as you are. So I figured I would at least kind of, unfortunately, like put you out there and see if you were willing to kind of go on record for anything. But that I agree. I mean, that seems like the consensus to me. That's why I brought it up again, not to kind of like put you on the spot, but more because I mean, I think we do see these changes like up and down the kinetic chain, right? It's not just at the hip. I mean, we've talked about this with other things before, but people get really good at compensating and finding ways to kind of work around it, especially successful athletes and that kind of thing. When we're talking FAI and that kind of thing, people get really good at finding ways to cheat and still successfully perform their task. And that's why I was curious.
We do see this consistently throughout the FII's literature, that there are different movement patterns between men and women, but sort of nailing down what are those differences has proven to be a little bit of a more difficult task.
So that was going to be, again, you're anticipating on my questions here. That was going to be my next question, as far as like, because I know there is some literature out there that discusses differences in how it manifests in males versus females. So, I mean, can you give us maybe a quick, is there anything that seems to be agreed upon as far as like, we see this in males, we see this in females, even if there might be some subtle differences, or is it just way too inconsistent and all over the place?
Yeah, I am going to lean on the side of it's pretty inconsistent.
Fair enough. Yeah, that's fine.
Yep. And I do think too, it's a little bit tricky. I myself am also guilty of this. We often lump hip joint related pain into one category, and then we're often including femoroacetabular impingement syndrome, maybe borderline dysplasia. And so, a lot of this biomechanics data is really messy. So men and women probably move differently. How they move is sort of still up in the air. I think the clinical take home is, evaluate movement in all of your patients with a single leg task. And then, at the end of the day, your intervention is going to target the impairments that you find, right? You're not going to change it based on if it's a male or a female, right? You're going to change it based on what you find with that patient. So yeah, I'm going to answer that question with a non-answer.
Yeah, that's fine. No. Yeah, that's right. Like it's all, it depends is definitely okay, right?
Yeah.
Right.
Yeah.
So, all right. So tell me on that note, we've talked about kind of some of this, again, conglomeration of different hip pathologies that get lumped in. I'm wondering from a prognosis standpoint and some of the research you've done, have you found, is there one pathology or group that you find is kind of like most recalcitrant or least successful with non-operative management?
That's a really good question. I would say that the literature suggests that non-operative management is quote unquote successful in about half of patients.
Right.
Now, what that success means is really sort of moderate improvements at best in terms of
Yeah.
pain and functional symptomatic improvement. In terms of those who don't do well, we haven't really found sort of like one group that is just not going to do well, right? Like
Right.
that the literature just doesn't support that yet. We know that
Sure.
there are some risk factors for not doing well. And one of those,
Yeah.
of course, the point of sort of today's conversation is mindsets, right? That has shaken
Yeah.
out time and time again. And is true. Multiple systematic reviews have demonstrated that. So I do think that, one group of patients that's probably going to see less clinical benefit, whether it's non-operative intervention or operative intervention, is going to be patients who are going into that with this maladaptive psychological response to their injury. And so we really need to think about how are we including that in our treatments.
Sure. Okay. And really identify that pre-surgical, right?
Right,
So
absolutely.
tell me, if you got, that's again the perfect setup here, because I wanted to just not, while we have you, right?
Mhm.
But not just focus strictly on the non-op stuff, but you've done some research as far as how it plays out post-operatively as well. So
Mhm.
can you tell us like what you tend to see as far as changes, both maybe from a psychological standpoint, but maybe also from a biomechanical or motor standpoint, what you see as far as post-operative changes and how that morphs a bit?
Mhm. Yeah, so it's interesting. We just finished a systematic review. It's in revision right now, but it included over 60 articles. And we sort of asked, one of the questions we asked was, do psychological health factors change following intervention in this
Yeah.
patient group? And there's very low level evidence to suggest that they change. About a third of the
Okay.
studies found that psychological factors did improve. About a third found that they got worse, and about a third were mixed. So we really don't know. And the reason that there's such variability is because the types of metrics people are using are different. And the sort of study inclusion criteria vary pretty
From
dramatically.
study to study. Yeah. Right.
Right, exactly. Different populations, different, yeah, all those different things. So, I think, looking at the types of studies, I am not convinced that the interventions we're currently delivering, whether that be surgery, rehabilitation, whatever it is, are improving our patients' psychological response to injury. And that's not surprising, right? Because the interventions we're delivering are not targeting someone's
Yeah.
psychological response to their injury. So it's unsurprising that it's not improving for most patients.
Yeah.
I think in terms of how people are loading their joints is also questionable whether or not that is improving.
Yeah.
In terms of physical activity, like we really want to zoom out and say like how much are people loading their hip? There was a systematic review that demonstrated that physical activity is not improved from pre to post-op. And so, globally loading the hip, we're not doing a good job of encouraging people to get back to, even just regular levels of physical activity. So
Yeah.
I think that, we have some improvements to make.
Yeah. Yeah. And that's why on a personal, like I've been pushing for force platforms and force plates in our practice. Because I want to know, but sometimes I question, I'm like, do I actually want to know? Like maybe I don't want to know. Like all these things I think I'm improving and changing that may not actually be changing. I'm like, maybe ignorance is bliss there. So
Yeah, yeah. Yeah, and it's like, what is the thing we most value, right? Like at the end of the day, we all want our patients to be happy, satisfied, thriving, right? Like that's our
yeah.
goal. And so, we know a lot of these biomechanical, movement-based, strength-based measures are important for joint health, overall function, ability of people to be physically active. And it's like, yeah, if we're measuring it, we better be changing it.
Yeah, exactly.
Right? Yeah.
Right. Yeah. So you touched on it a little bit there about, and again, I alluded to it a little earlier. Like one of the things I've loved about reading some of your stuff is that I feel like I am way better now, and there's tons of literature out there now on identifying some of these red flag things and some of the psychosocial considerations. But I feel like one thing as a physical therapist, sometimes I identify them. Okay, now what? Like great, I see this, but I have no idea how to deal with it because I feel like again, like I don't have an extensive enough psychology background,
Mhm.
and I feel like that's one of the things in terms of like academic curriculums. Like I'm old, but I don't remember anything in school that was like, hey, when you see this in your patients, this is the best way to remediate it or that kind of
Mhm.
thing. And I know you've done some research on that. So I wanted to kind of give you the platform to maybe expand on some of the stuff that you're researching. And again, like once you've identified some of these things, some steps you might take to be able to do from an intervention standpoint or some strategies.
Yeah, absolutely. And I first want to validate, like, you are not alone. Like
Yeah.
that is most
Okay. Yeah.
clinicians' response, right? And I think that that's what we heard when we interviewed physical therapists about this. They were like, I know this is a problem. I see it in my patients. I don't know how to help. And I think
Yeah.
that that's the step we're at, right? Is like, how do we help?
Yeah.
And so, psychologically informed practice is not new. The groundwork has really been laid by many of the pioneers, the Steve George, Frank Keith, Kristen Archer, Chris Main, Peter O'Sullivan. Like I could keep going. I don't want to leave anyone out, but like there are
Yeah.
great people who have sort of like laid the foundation for what this can look like in clinical practice. And so
Sure.
now we're all just kind of building off of that to figure out how can we implement it and how can we actually make it something that rehab clinicians are comfortable with and that patients respond well to. And
Sure.
so, the idea of psychologically informed practice is not that we're getting rid of what we already do well. It's that we're trying to also address our patient's mindset so that what we're doing well works better, right? We're trying
Yeah.
to maximize the benefits of what we're already doing well. And so, we know in our patients that their recovery from injury or pain is both a physical and emotional experience. Always, 100% of the time, because we're human beings. And that's just how we're, I guess the blessing and the curse of being a human being.
Yeah.
Um,
Yeah.
and so I think the question is, okay, once we identify it, how can we help? And so this really comes back to our normal clinical decision making that we're also good at, right? We identify a treatment target, and then it's what tools in our toolbox to change that mechanism, right? And so if my patient is struggling with fear of movement, right? They're afraid to move. They don't trust their body. They associate movement with pain, right? How can I start to uncoil that in a way
Right.
that makes them feel confident in their body and reduces their fear to move? And so maybe one thing I can pull from my toolbox is some graded exposure, right? I can walk them through, okay, here's how we can do this. Maybe it involves a little bit of movement retraining. Maybe it involves a little bit of, who knows what other impairments are there. But we walk through it and we say like, look, you're doing this in this way, and your hip doesn't hurt. Like, what does that tell you about your hip?
Yeah.
Right? And
Right.
so it's like exposing them to movement without pain, in order to build their confidence in their bodies, in their ability to move and reduce that sort of pain anxiety or pain related worry that typically prevents them from moving their bodies. And so there are a variety of different psychological and mind body interventions that we can incorporate into psychologically informed practice. The list is very, very long, but a
Yeah.
few might be very simple things like diaphragmatic breathing, progressive muscle relaxation. Something that a lot of rehab clinicians already do really well is setting SMART goals, right? And
Yeah.
we know that that's a really evidence-based way to improve self-efficacy. So let's keep doing that. Let's keep doing it well. Um, And then so once we've identified, okay, here's the problem, here's what I think the appropriate intervention for that might be. The next question is like, okay, how am I going to deliver that intervention? Am I confident in my ability to do it?
To
Right? If
package it. Yeah,
yes,
right.
yeah, then great. Like if you feel confident to do it, then do it. If not, then how do I get my patient the support they need? Because ignoring it clearly like it's not working.
Yeah, right.
Right?
No
Right.
doubt. Yeah.
So the question is then like how can I get them these skills if I can't be the one to deliver it? And there are a few options. So there's tech enhanced interventions. So there are app-based interventions. I'm not affiliated with any of these, so I'm not like promoting them because I get anything, but Headspace has a pain series. Calm app. There's an app called Curable that's specifically designed for chronic pain. There are several other apps as well. There's also VR-based technologies. In our group, we've done some research with one called Reliever, which is a multimodal, psychologically informed intervention for patients. It's FDA approved for like chronic low back pain and fibromyalgia, but hasn't been trialed in other MSK populations. So, we could lean on technology to fill that gap, right? Like they can do that in the waiting room before you see them or at the end of the session, or, you can integrate it in that way. We can also team treat these people, right? Like we can refer to mental health providers that we collaborate with. And so, having those referral networks set up ahead of time, understanding, okay, what's the best way to facilitate this referral? How do I do a soft handoff? How do I have this conversation with my patient in a way that's not going to, damage the therapeutic relationship that we already have?
Sure.
Exactly. And those are all the soft skills, right, that are involved in having these conversations around how a patient's mental health is impacting their progress in physical therapy. And so, I think that those would be all of my suggestions, right? Identify the problem, identify the time that problem's occurring, identify what mind, body, or psychological intervention could potentially impact whatever the problem is that you identified, and then figure out how you're going to get the patient the intervention that they need, whether it's you, technology, or a mental health professional.
Yeah. Okay. So your communication there just kind of brought up one more question for me. Sorry, so I'm kind of going off script. But,
no, it's great. Hopefully I can answer.
So one question I've always had, right, is again in terms of like performing that remediation when I've identified some of these things, right? I always default to like graded exposure because that I feel like I can do pretty easily. And again, setting like small, smart goals to kind of build that confidence and self-efficacy in them. And also just kind of pointing it out and reinforcing like, here's where you were 6 weeks ago, here's where you are now, right? But one thing, fortunately, I have not had to do this a lot, but we do have like a sports psychologist that we have as a resource. But I'm wondering, like, how do you make that determination? Like, how do you know when it's time to pull the trigger and pass that person on? Are there any specific cutoffs or points where you're like, okay, now it's time? Or is there any kind of agreed upon standard?
Yeah, so I would say the things that are agreed upon are certainly any red flags, right? Like any signs or symptoms of a mental health condition like depression or anxiety that's not related to the patient's presenting problem, right? Like as a rehab clinician, I can help you through your emotional journey with your hip pain. But I am not here to treat your depression or your social anxiety or right, like all of the things that are outside of our scope of practice. So those are all certainly, flags that I would be doing a referral. And it's not either or. Like we can be doing psychologically informed practice and refer a patient for additional mental health care. So it doesn't have to be an either or. I would say other red flags, of course, are like, major changes in personality, any talks of self-harm or harming others, all of the typical red flags we would think of for someone who's really in a lot of emotional distress. Those are obviously red flags to a mental health provider. I think that outside of those red flags, it's really going to be clinician dependent. Like I might not be a clinician who has a level of comfort and competency with these interventions. So I might be referring a lot because even though it's within my scope of practice, it's not a skill set that I have, right? There's a lot of things in our scope of practice that we can't be experts in everything, right? It's hard to hard to do that. And so, if it's not something I'm comfortable with, I'm going to be referring a lot more frequently. And that's totally fine. Like, there is no shame in that. Like, as long as we're getting our patients the help that they need, I think that we're doing our job.
Yeah.
So yeah, and then in terms of like, are there any cutoffs? The screening tools that I use are really measuring a patient's um, cognitive and emotional response to pain. So I'm not measuring things that are outside my scope of practice. So there's not necessarily like a cutoff on the pain catastrophizing scale where I would say like, oh, this is beyond me, right?
Okay. Yeah, that's what I was
But
thinking.
if you were using a screening tool that was measuring, generalized anxiety or depression or like some other construct, there might be a cutoff where you would say, like, this person needs a mental health professional. So it depends on the screening tools that you integrate into your clinical practice, and having a really robust plan ahead of time for what I'm going to do when the situation presents is really important, right? It's important for the
Yes.
patients, but it's also really important for us because you don't want to be stuck in a situation where you're unsure what to do or how to help your patient. And so I think that really thinking these things through on the front end, having a good policy and procedure, and also a mental health crisis emergency action plan, really important to have those in place.
Yeah, absolutely. And it's when like we've reviewed some of our post-op protocols, that kind of thing recently. And when we were doing ACL, we realized like really have like a go-to list of like mental health people that it's like who does it? And we had to kind of really investigate and ask around. And through that, fortunately, we've been able to kind of develop kind of a regional list of people that we can refer out to. But I feel that's one thing that we don't always necessarily feel comfortable with or have like an agreed upon, like, okay, like this is something we need to deal with. And maybe, like you said, we're not getting it done by ourselves. Like, coming to that self-awareness and recognition sometimes is a really important step just in terms of the overall outcome of the patient. So.
Yeah, absolutely. I totally agree. And I think facilitating those relationships with people that we would be referring to is really important. Like, if
Yeah.
they know who you are, they know the types of patients you're going to be referring, like building that interdisciplinary team is really key because, if you can facilitate a soft handoff where you can say, like, I know this therapist or I know this psychologist or whoever it is, and, introduce the two of them or like so that it's not such a scary transition for the patient, that can really help to increase the patient's buy-in for
Yeah.
getting mental health care, sort of like destigmatizing it, talking about it, having it part of your clinic flow. Yeah.
Okay. Absolutely. Well, this has been awesome, but I recognize I can't take up your entire day. So I feel like I could again, like all these questions keep popping up and that kind of thing. I could feel like I could extend this podcast another half hour if I really wanted to, selfishly, but I recognize we both have other paid, employment we need to do. So one of the questions I wanted to ask you about, that we kind of asked a lot of our guests, is now in 2025, tell us something that you are trying to kind of either research or what kind of project you have ongoing or something you're trying to get better at. Tell us kind of what's in the pipeline for you, or just kind of some of your general interests right now.
Yeah, I think that's a great question. So right now we are launching the open pilot of our the intervention that we developed. It's called Helping
Awesome.
Improve Psychological Health. It's a HIPS mind-body intervention. So it's a 6-session mind-body intervention delivered by physical therapists for patients with chronic hip joint related pain. So yeah, excited to launch that here in the next few weeks. And
Okay.
then just yesterday, found out that we got a DoD grant to look at biomechanical, muscular, and psychological factors associated with hip joint pain and cartilage health. So excited to look more into a lot of the things that we talked about today. That work's
Absolutely.
being
Yeah.
led by my close collaborator, Mike Simon at the University of Kentucky. So great group there as well.
Okay.
Yeah, we'll see what else hits, but those are the two that we're excited to get rolling on here in the next few weeks.
Awesome. And is that app strictly in the research phase, or the technology you're describing, or is it available for general consumption for clinicians at this point?
Yeah, so the hips mind body intervention right now is only in the research phase.
Research phase. Yeah, okay.
Yeah, hopefully, but the concepts within hips are available to everybody, right? And
Sure.
so often when I present, I talk about the process of, okay, here's what I thought hips was going to be. Here's what I learned, right? Because I interviewed PTs, I interviewed patients. I really wanted to learn what people would like and what physical therapists would deliver. And it turned into something very different than I originally proposed. Which is how good science works, right? We need to be open to changing our minds. And so yeah, the components of hips are available to everyone. It includes some exposure, it includes SMART goals, it includes some coping statements or cognitive restructuring, it includes some pain neuroscience education, it includes, so the components are available for everyone, but the package itself we're still refining and testing.
Sure, understood. Okay. And then last question that we ask everybody. Tell us something, like if we look at the MGH and Harvard bio, right? Tell us something not on there. Tell us something personal about you, any other like hobbies, interests, just kind of personal asides.
Yeah, sure. Something interesting about me. So I like to spend most of my time outside. Backpacking is like the biggest hobby in our house. So yeah, honeymoon, we backpacked through Sequoia. Every year we go backpack somewhere new. So yeah, love being outside and try to spend as much time as we can out there.
Awesome. Good thing you did that before wildfires and everything hit, right? So
yeah, no, we actually went after, well, I mean, these most recent wildfires, obviously not, but when we were out there, it was 2022 and there had been some recent fires and it was really crazy to see. But beautiful park, highly recommend Sequoia and Kings Canyon. Yeah, it's a beautiful area.
Awesome. And then where's the go-to backpacking place in Massachusetts? Because obviously you must be in the Boston metro region, right? Which doesn't lend itself to a lot of backpacking, right?
So my husband's actually from Asheville, North Carolina. So we spend a lot of our time, somewhere off the Appalachian Trail. And, I hopped around Appalachia for my training, Kentucky, Ohio State. So, we like to spend a lot of our time sort of navigating the East Coast mountains as much as we can.
Yeah. Awesome. All right. Well, again, I can't thank you enough for your time. This was just, again, selfishly informative, right? But hopefully our readers or listeners will feel the same way here. But this has been great to have you on. And again, I can't tell you how much I appreciate your time, especially since I kind of cold called you when I reached out by email, right? So
happy to have these conversations. I think they're really important to have. So I'm grateful for the opportunity. And if anyone wants to continue the conversation, feel free to reach out. We can email or hop on a call. I'm always happy to chat with anyone.
Yeah, and I always kind of finish with any resources you have or articles, that kind of thing. We'll put it in a kind of finished show notes edition once our editing team here cleans this all up and gets rid of all my gaffes and everything. So
awesome. Well, thanks, Dan. I appreciate it.
All right. Thanks again, Kate. Take care.
Yeah.